I was working in the respiratory area, and I was beginning to get first-hand view of the huge problem that we have in this country with asthma, which at that stage was, in my opinion, very badly managed, and we had a very high percentage of deaths from asthma, a lot of which should never have happened if the patients had been well informed. And I started to get on my high horse. I started to talk to one of the respiratory specialists about the lack of knowledge, both from the point of view of patients and in some respects the medical profession with the management of asthma, and I was seeing this firsthand in the ward. And I also was concerned about COPD patients who I also felt were perhaps not getting the best management that they could. So I talked to Dr. Malcolm Sears, who was head of the respiratory unit at that stage of the piece, and very sympathetic to what I was saying. And he told me that New Zealand had very recently, just within the last month or two, appointed 2 asthma educators. There was one in Christchurch and one in Hamilton. And he said that he thought it would be a really good idea if we had one here in Dunedin. So the outcome of this was, he said, why don't you do it yourself? And I hadn't even thought of doing it myself. So I gave it some thought, and he said to me that he'd back me and he'd try and get the hospital board to support the position. Well, they did. They finally came up with 20 hours a week, which is ridiculous because I worked for about 40 really. And anyway, I was appointed to the position. I think I was 48 at the time, and I have to say that it was the best thing I ever did. I had a total change of direction. The great thing about it was that I was appointed to the position, and then he virtually told me to do whatever I liked. I had no direction, I had to make it myself, but that was quite fun. The other 2 who had been appointed very recently, he sent me up to see them. I went to Christchurch and I went to Hamilton to see what they were doing and how they'd set it up, and that was a big help. But the interesting thing was they were both nurses, and I don't know whether I'm right or not, but I think I might be the only physio that's done this. It seems to be picked up by the nursing profession, basically. So I actually didn't know where to start because it was such a gigantic problem. So I started off seeing adults. We told the local medical fraternity that the position was available and that patients would be seen and helped and advised. And I made it very clear that it was an adjunct to their own treatment, that we were just going to try and explain to people how to manage their condition. And of course the problem with any chronic disease is that you've got to take medication even when you feel well, which is a huge barrier to get over, and that's where it was falling down right from the word go, because the dreaded word steroid had people running for a mile. And the other big thing was in totally inadequate use of inhalers. I don't think I saw one patient that was using an inhaler correctly because nobody had spent the time with them. And it is such an important part of their management, because if it wasn't getting to their lungs, they might as well be blowing in their ear hole. And that was a big thing. I also used the peak flow meter an awful lot because it was a guide to how much obstruction there was in the airways, and often they weren't perceiving that, but it was there. And I always remember teaching medical students once, and I used to love doing this, and I'd often say to them, what's my blood pressure? And somebody put up their hand and say, well, you know, what's your age? So I'd tell them my age, and then you'd say, well, you'd be about 130 over 70. And I said, would I? How do you know? Well, because that's what you should. I said, yes, but you don't know, do you? And the same thing applies to having some objective measurement of the obstruction in the airways. And you can guess that, but you don't know it until you either do sophisticated lung function testing or you use a peak flow meter. And it was such a handy tool, and we used to get patients to monitor morning and night their peak flow rates for a certain degree of time, looking for the diurnal variation, which is part of the asthma, the way it presents itself. And also they could see and they began to realise what you were on about. And then quite often, if we changed medication or got them onto inhaled steroids or more efficient treatment of some sort, they could also then see the result of using that because it was demonstrated with their peak flow rates, etc. So I became a bit of a crappy old tart, really, I suppose, about the use of that. So I started off with patients and I started seeing them, and I think one of the things that was really beneficial was that I started to hold clinics, and I would have a patient for at least an hour, and it takes that long for them really to start understanding where they fitted into their own management. Action plans came in during the course of this, and they were phenomenally helpful as well, so that they knew what to do and what signs that they had to act on and that sort of thing. A lot of people just didn't have a clue. I remember being absolutely appalled at some of the interviews that I had when the patients or the parents of children were describing to me how this condition was affecting the entire family. And that was unbelievable in some cases. It was really, really, really bad, and I don't think anybody had even thought about it. So that was quite interesting. And then I tried to extend this a little bit to include the children, and of course in 20 hours a week this wasn't easy. And eventually, after I'd been in the position for about 3 or 4 years, they agreed to another 20 hours per week, and I was able to take on another nurse who worked with me who was really brilliant. We got on really well together, and she had been in paediatrics, and she started to take over the children a bit. From that we graduated into all sorts of things. We spoke out in the community, we did a lot of teaching, we went to medical practices and held seminars on asthma. We were involved eventually in teaching most of the other allied health professionals who were based in Dunedin. We taught nursing, physiotherapists, dentists, would you believe, medical students, training college. We covered the whole vista. So it was a big job, and it was a lot of fun, but I just loved it. And I think one of the things that really made it for me is that as a physio, when you finish your training, I felt this very strongly, and I think probably others have as well, that you feel as if you're a jack of all trades and master of none because of the diverse nature of the profession. And it's not until you've got through, well, this is obviously catered for much better now, and then you move into an area that suits you and you increase your knowledge of that area. Well, of course, this is what I did when I moved into asthma, and I was pretty ignorant of a lot of things when I did it. For example, the drug therapies, I really had to work on learning more about the drugs that were available. The drug companies were hugely supportive, actually, and gave us a lot of help and a lot of free samples, and one of them actually sponsored a trip for me to go to Brisbane to a conference, which was wonderful, and they paid for that. So I was very friendly with the drug reps, and it was to my advantage.